Good morning, we are Alejandro Sánchez
and Dr. Carlos Parra, and we are here today with all of you and with the IPD house to talk about something little known to clinicians but very useful for lab technicians, which is IPD's replace system.
What does the replace system offer through the Model Pro software? The ability to simply, by explaining how easy it is to go from a scan body system that offers a continuity of digital flow to having the possibility of converting it to digital IPD flow with the possibilities they offer.
We live in a world where artificial intelligence is becoming more and more common. Look at the image we have on the screen in which the intelligence itself generates, as would be a scan body. But a scan body is not intelligent. Not all scan bodies transmit in a way, let's say, legitimate, the XYZ position. Neither angulations nor other systems that can be implemented in this type of flow. Hence the importance sometimes to change from one system to another or to change from one library to another. Because not all libraries behave in the same way and do not allow all the restorations that we clinicians would like. This is something that Alejandro is quite unaware of from the clinical point of view. And we think that with the same scan body we can do all the tricks we want, or that we can offer the patient all the solutions we want with a single scan body. This is the reality in the laboratory, and I believe that talks like today's will also help clinicians a lot to understand why this is happening and what the laboratory needs in order to solve these problems. As we were saying, it is becoming more and more common, Alejandro, for patients to come to us for consultation with implants from different periods of their lives, or sometimes performed in different clinics, because the patient moves from place to place or changes dentist, and situations arise such as the one we are seeing here, where the patient's mouth is full of a compendium of brands, models, different connections, and we have to take impressions. And then many times we require or we use scan bodies that we already have in the office or that the manufacturer himself has provided us with. And when we send all this digital information to the laboratory, they pull their hair out because there is no continuity between one and the other. The libraries are not compatible, and in the end we make our work very difficult for ourselves. In the end, this type of printing with different connections and different scan bodies is also a headache for us. So how do we then remedy this at the laboratory level?
In the end, the system will logically condition the choice of the scan body or the choice of the implant that the patient carries in the mouth. It will really condition us in two ways. One direction will be the flow that the library associated with the scan body will allow. If it can work direct connection, if it can work angled, gingival height, connection height, angulations, all that. Some provide it and others do not. And something also very important, which was almost the reason why we started using the replace, would be the possibility of accommodating the digital analog of IPD, since in some commercial scan bodies they didn't even have digital analog. So we couldn't get a positive model to work on it.
This also limited them a lot when it came to being able to work on aesthetic changes, profiles, or other emergencies, because there was no possibility of working in a way with an analog. As you said, digital, there was only the connection part and the possibility of working directly with the connection.
Exactly. Only virtualized in the design software. In this situation that you propose with so many different implants, each one of them proposed different workflows. So if we wanted to do a screwed one, or if we wanted to do a direct implant one, some offered it, others didn't, so the design management and above all, production management was very complex.
Also note that this type of situation we are discussing, in which a patient carries different implants from different periods of his life, also leads us to another problem if these patients are not from our practice but have come from referrals from other practices. Sometimes they do not have a registry book of these implants, they have not been given the typical booklet with the identification sticker of their implant, or sometimes they do not even have access to the clinical history because that clinic has closed. That is another complication at the clinical level, at the work level, because it is difficult for the dentist to identify which implant the patient is carrying, sometimes because of the similarities, many times, and the imitations that exist between some brands and others in their bodies and their connections. From there, we also have the ability to make an identification through the IPD website with its implant identifier, which will help us to find the best solution for that implant that we do not know in the clinic. If in addition through the web we can identify what solutions we have, even if I have a scan of IPD already, that also facilitates communication, right?
This is exactly what you are saying about the traceability of the implant and the traceability of not having a patient record to identify which implant he brings to the laboratory something very similar happened to him, which was the traceability of the scan body capture that he had done directly in the clinic. The clinic may not even know the manufacturer of the scan body, but knows that the connection coincides with that of the patient's implant. But in the lab, we found that when we started to work on it, we found no digital libraries. We don't know if there are libraries for our design software adapted for it, and it was very complex to work on different scan body systems. Without being sure that the path to which the definitive prosthesis wants to lead us was the correct one. Hence the need to unify this type of multiple implants, different brands or implants that did not have a correct traceability in the clinic. For this, what does IPD propose? It was a bit of a game depending on what type. Regardless of the type of scan that we receive from the clinic, to use an intermediate software between the design software, which would be Model Pro, which would be a tool that we would use to agglutinate all the different workflows that might arrive from the clinic. In a single line of work, that would be IPD, both for the reconstruction of the prosthesis and for the placement of the digital analog.
Even though we take impressions with different systems, with all that entails, because not all the scan bodies are going to be able to transmit the same information, the software is able to bring together that information that I send you from the clinic and convert it to a single stream.
Yes, I actually have a sample of how that would happen. Logically, we would do a simple work order, which would be to identify which pieces are going to carry the digital markers in this case, and in which upper arch, lower arch. In other words, to provide the software with the information about the scan body situation that we are going to find in the treatment. From there, the software would have within it the possibility of unifying meshes. If you are going to take an impression of the emergence profile, and I will take an impression of the digital scan of the scan body that we do not have correct traceability on it, we would do a matching, we would make a best fit on it, and we would unify the emergence profile with the scan body. And then simply by identifying what type of implant in the library, we would do a matching, we would locate exactly the position, and we would locate the original implant in the library. And we would locate the original implant that is in the mouth with the correct scan body that belongs to IPD in a comfortable way. Even if I say outside of the design software environment, because here we would not talk about designing, we would just identify correctly. And once we have identified it, then simply, as I was seeing in this very explicit image, it would be the original scan body, we had it in green, I would do a matching on it, and automatically by the algorithm that Model Pro presents, I would locate in space the scan body, both rotational and anti-rotational, whether it is an individual piece or a multiple reconstruction. From there, what happens? I can take the IPD scan body with me in space with my working model, and I can take it with me. For any design system, be it Exocadi 3-shape blender, any system that I could manage the continuity of the design, but through the IPD scan body, with the advantages it would offer, as we all know its custom interface, the direct library, implanting the position of temporary abutments, and above all to unify all the digital analogs in the same double-screwed situation, which is the first need that the laboratory ends up turning to the Model Pro with the replace.
For me, one of the main complications at the clinical level was to be able to ask for solutions that were at best angled or corrected. So that's what we were talking about, too many confrontations of implants at different stages of their life. Because an implant that had initially been placed to restore a unitary piece, suddenly when working together with 4 or 5 other implants, it is not placed in the best position or does not have the most adequate angle for that restoration. For me, it was essential that you could correct that type of angulation, take it to the working arch to make a group function of the whole restoration that we are going to place in the patient. If that solution does not exist at the time of working with the workflow, with the original library of that manufacturer, because sometimes they are old or they are implants from many years ago, even scan body does not exist for this type of connection. Being able to work with or drag these types of solutions to replace and be able to correct them, for me it seems fundamental.
If in the past there's been a lot of dissatisfaction with the expectation of the prosthesis that the patient demands in the clinic, the clinician prescribes that type of prosthesis, and there has been a lot of frustration in the laboratory when we have encountered different brands with different fields and with different flows of compatibilities, and not being able to satisfy the patient's need since the same library did not offer me that possibility. And I believe that this solves the losses that were occurring in the past, the traceability of these products.
And also, unfortunately, this is a situation that is becoming more and more common in the practice because we have more and more long-lived patients with more implants placed a long time ago, and the lack of knowledge of where they have had them done or the brand they carry, which for us is of great importance. For us, it is a great help to be able to offer this type of solutions that unify our problem and give us continuity to the restoration.
For example, my colleagues transmit to me a lot of doubts about, well, in the end, we are going to put something in the space that comes from a digital marker of a brand, and we are not going to take it to IPD, and always a little bit of doubt whether we are placing it in the spatial, in the z-axis, or if the rotation of the connections is going to exist. There is a very comfortable exercise that I recommend, which was to manage originally the whole model as it arrives from origin, even print a model and put an analog to it and model it digitally, and then do this that we see in the image, make the overlay of the image, IPD transformed image, and manage it and compare the location of the connection.
Compare one validation.
We do the validation, and that generates a lot of confidence to the technician when using the tool, because as we work a lot spatially, in many cases we also work virtually without generator model requested. A lot of doubt whether I am working in the right place. That soon disappears, because as soon as you start to get a little familiar with the tool, you gain confidence in what you are making. Virtually no mouth, and it is in the right place. And the clinician receives it in a very comfortable way, because he doesn't have to worry so much about whether we can keep that traceability, but that the prosthesis he prescribes is the right one. We are going to have digital resources to be able to fabricate it.
It does seem very important to me. I don't know how you feel about the work order being very specific about what tools we're using, because of course, if we have a compendium, we have a mix of implants placed in the mouth. It is also very important that the clinician indicates on the work orders the position of the implants. I have used such a Cambodian and such a brand for such a model so that you can then do that matching.
This has changed so much that now the laboratory needs the traceability of the scan body that you have used rather than the implant. Because having the location of the traceability of the scan body, if you give me a reference or you give me what it is, it will directly place the correct implant, and from there we can do it. If that traceability is not correct, it generates a lot, especially because even the same tool that we would have to give the conversion, if I don't give it the correct data, the conversion would assume risk. That's a very important factor, what you just said. And with that, from there we can start working. Here in this image we also see, well, if we want to continue and we want to print our model, what I propose is that location of the digital analog with the benefits that the IPD digital analogs propose, to convert it into a unitary analog where we can locate a basal screw connection and a vestibular screw connection in order to generate a passive model with the correct IPD calibration master, and have a traceability of all the brands and all the scan body in the same digital analog connection.
And to be able to get a localized master validation model, as you were talking about before, and be able to work under that compendium in a single model.
Well, and with that we finish the module of what would be the replace of implants through Model Pro. I hope that I have solved many doubts, and we remain at your disposal for any questions.
I think it is a fundamental tool. Above all, it gives us, as we are seeing throughout the day-to-day, one more solution to solve, let's be redundant, problems that we encounter on a regular basis in consultation, especially when working with patients with long evolution or patients with different implants. It was a big headache to know what to send you, how to take the impression, which tools to use. I don't have a specific scan body for that implant. It is to be able to use different tools to give a solution to that treatment so that you can put it all together. In a single software, it optimizes the flow a lot. I think so. So what Alejandro said, it has been a pleasure to share with you. You have all the information you need about this on the IPD platform, and you can contact us through them. And if you can't find us in social networks, ask us any questions you may have about these kind of cases. A pleasure, and again, thank you for being here with us. Good morning, thank you very much.